So in this video, I wanted to use it as a case study of our process at the back specialists and how we're helping this 63-year-old gentleman. He's a lovely chap. He wants to be very active. He loves the outdoors. And while he can't run at the moment, he still manages to get on his mountain bike and cycle the trails in Wicklow. But beyond that, he has to take life very carefully. His back simply won't let him do more. So in his history, he's had back pain for a long time, maybe back into childhood. And so there's a big clue there. The pain spreads across his low back and more recently into the right sacroiliac joint region. Standing or walking for too long brings on the pain. So he also notes a lot of stiffness in his neck and shoulders, and he even says that his head feels heavy at times. So there's another clue. It's important bit of information there. He's tried everything. Physio, chiropractic, massage, injections. He's even seen the pain specialist in the Beacon Hospital, but nothing has really touched the pain. So the only thing that brings him some relief is when he tilts his pelvis backwards into what's called a posterior pelvic tilt. So there's another important clue for us or piece of information. So when he came in to see us, and after our history intake, we started with the Selective Functional Movement Assessment, or the SFMA for short. And the SFMA is a system that's used to break down movements into smaller component pieces and to categorize them to help figure out why someone is having the problems and what's the best way to build them back. So we use it to understand whether the restrictions in the body are because something is genuinely stuck, like a mobility issue, or in the joint or the muscle, or whether the person's having a motor control problem, which basically means the brain is putting the brakes on the movement as a protective mechanism. And how you treat those two things are completely different. So with the SFMA, you would classify movements into 4 categories. You can have a functional, non-painful pattern. The movement looks good, it doesn't hurt, there's nothing to do there. So practitioner, move on. You can have something that's functional, but painful. So the movement works perfectly fine, but it's producing pain. And that can be a signal that the pattern itself isn't the problem. The pain is coming from somewhere else. You can have a dysfunctional, non-painful pattern. The real keys to this system in getting success. The movement doesn't look the way it should, or move the way it should, but it doesn't hurt. So these are often the most important patterns to fix because they're going to show us where the body has lost access to normal movement and can be driving force and load into the painful area. And fourth, you can have a dysfunctional, painful pattern. This is where the movement is limited and it hurts. So this is where we don't actually exercise this pattern. This is where hands-on techniques or some needle work or maybe some red light laser therapy comes into play. But it's a mistake that can be made where people try to exercise this pattern. It's not the right time for that. So by sorting out the movements in this way, we can tell what's safe to work on, what really needs to be restored and matters for that person, and what can be left alone for now. So that way we're not going to waste time stretching or massaging something that isn't actually tight, or we're not going to be loading something up where the brain is trying to protect it. So for example, in his neck, we found restrictions in flexion and extension around C3. Turning his head to the left was only possible when he's lying down, not standing. So that's not a tightness issue, that's the brain limiting access, the stability and motor control dysfunction. In the shoulder, the pattern suggested that there was a possible link between the right shoulder, the rib cage, and the low back. Very, very interesting. His forward bend initially looked like there was tight hamstrings, but once we assessed it on the table, they weren't actually tight. They were just acting that way. His right hip was tight at the back of the right hip, so pulling the knee to the chest. And his rotation, full body rotation to the right was limited. His balance was off. And through digging it out, we found a vestibular problem, an inner ear issue, which would explain the neck stiffness and a whole host of other dysfunctions that we will find later on. And in his squat, both ankles were restricted, but interestingly enough, the right ankle was more so. And in his backward bend, that's where his back hurt immediately. So straight away we knew avoid extension exercises for now. But we did find the upper spine, upper to mid spine tight, and his Faber test is where you pull the hip into flexion, abduction, and external rotation, and that showed the hip joint on the right hand side was blocked. And if you can't move your hip, your back will often move too much by way of compensation. Now, next, we tested his muscles at a neurological level, and this could be a little odds to people if they've never had it done before. It's not about raw strength, it's whether the brain trusts a muscle to do its job. So sometimes the brain will turn up the volume on a muscle, making it overactive and tight. That's actually called up regulation, if you want to look it up. And other times the brain will turn down the volume, making a muscle underactive or a little hard to switch on, and that's known as down regulation. Think of that as a dimmer switch. So in this case, here's what we found. With this gentleman, his right quadratus lumborum, which is a low back muscle, was up-regulated, working far too hard. And no one had touched it before. His right hip flexor, the psoas, was down-regulated. The brain wasn't letting it pull its weight, basically. His glute max on that right-hand side was up-regulated, and in the process was dimming down the function of another hip flexor, the iliacus muscle, and that has a pain referral pattern into the low back. His low back muscles in general were dominating, while his deep core muscles were down-regulated, so they're struggling to do their job and provide enough stability and switch on. The right ankle restriction was a big key we found, and it was actually feeding a lot of the problems up the chain. So when we analyzed his gait, how he was walking, we saw that he wasn't shifting his pelvis properly onto the right hand side. And ironically, that shift would give him the exact posterior tilt that his back craves, and it would have unloaded his spine on the right hand side, but his body was avoiding it. So very likely that's because of that old ankle injury or the vestibular issue that's going on with him. So it's a good reminder that every action has an opposite and equal reaction. So when one muscle is overworking, another is almost always underworking. So our job would be to calm down what's working too hard and wake up what's gone a little bit too quiet, so the whole system can get back into balance. So for this gentleman, we calmed down that overactive quadratus lumborum with a mix of hands-on therapy, some dry needling, red light therapy, and then we reactivated that inhibited psoas by putting it to work with some very targeted, specific exercises. We restored the right ankle mobility. We retrained balance through the vestibular system, that inner ear system, and we rebuilt the pelvis shift and tilt in walking. And all of that will give him a chance to finally let those painful areas calm down in the long term. So about halfway through the program, we're going to add things like the functional movement screen and capacity testing. So think of the functional movement screen, the FMS, like a quality check. It's going to look at big movement patterns such as squatting, lunging, reaching, rotating. And it's going to highlight any weak links in the chain. But that's only part of the picture. We also run load tolerance and capacity tests. So these are going to tell us if the muscles in the spine and the hips are actually strong enough to handle the demands of daily life, daily active life. So we test things like lumbar flexion and extension endurance, and we're going to check side planks for lateral trunk stability and capacity, perhaps some single leg bridge holds, calf raises, and other measures of postural control and strength. Now, this isn't just testing for the sake of it. We want to compare the right versus the left. We're looking for those asymmetries. We're spotting positions or postures where the body might be a little bit vulnerable if we push the body too much, and we're finding the margins where things break down. So why do this? It's just not enough to simply feel better. We need proof. We want that proof that the body can tolerate loads. It's the difference between being pain-free in a clinical setting and being bulletproof out there in the real world. So once we know these weak links, then we can design precision strength and conditioning plans that's unique to the person, unique to their goals. Remove the guesswork, just have targeted training that balances the system and protects the back and the body long term. So you can see that progression would build into that final stage, what we call that return to confidence stage. And that's where we take all the changes that we've made and apply them into real life for this person. So confident running, bending, lifting, exercising, and doing all of those kind of activities that he wants to do and have a lot of meaning to him. So, in short, the aim isn't to just reduce pain. The aim is to also restore trust in the body, to know that you're much stronger, more balanced, more resilient now, so that you can get on with moving with confidence. It's not about endless treatments. It's about calming what's overactive, reactivating what's a little dimmed down, getting to those root causes, and then rebuilding that resilience. So hopefully from this video, you can see, when people ask me, what does this involve? Do you give stretches? Do you do massage? Do you give exercises? Do you do needling? Do you do strength work? And I answer, yes. It could be all of those. It could just be some of those, but it's always in a very specific dose that's applied to very specific regions for very specific reasons. So nothing we do is random. Everything will have a reason behind it. And I think this gentleman's story proves that there's no such thing as non-specific low back pain. There's always a reason. And when you find it, you can finally build that roadmap to recovery. Look, I hope that was entertaining, enjoyable. You got some value out of that. You can see the process of what we feel should be brought to successful rehab. Thanks a million for watching. We try to put out a good amount of content, valuable content, shorter form content. So if you found this valuable, please consider liking and subscribing to the page. We'd really appreciate that. Thanks a million. Take care.